Good morning, everybody, or good afternoon, depending on where you're joining us from. I would like to welcome everybody to our Hope Connect session on Drug Prevention 101 with Dr. Rebecca Haines-Saah. And I am going to introduce Tyla, who is our acting director of Mom Stop the Harm and the Stronger Together program manager. Just a few housekeeping things. We are recording, and people are invited to put where they are joining us from in the chat. Tyla will do some opening remarks and talk a tiny bit about our programs. And from there, Tyla will be introducing Petra, who will do a land acknowledgement and also introduce our speaker for today, who we are very pleased and excited to have. After that, there will be a time for questions. We invite everybody to put your questions in the chat, and then we will get to the questions proportion. So, Tyla.
Well, hello, everyone. It's so wonderful to see so many people out today joining in on this, for this amazing presentation. And I know it's amazing because I've worked with Dr. Saah numerous times during my time of being a member of Mom Stop the Harm. And yeah, it's always great. It's always just an amazing time. The amazing is just the word for today, obviously. So we have our Stronger Together program. We do have two teams that do this program within Mom Stop the Harm, and that's only because of how we've received our funding. So we had our BC team who received provincial funding the year before we got our federal funding from Health Canada through the SUAP, which is known as Substance Use and Addictions Program funding. So we have both teams are going very strong. I think our last count was a total of 41 Healing Hearts groups that were established all across Canada, and another 41 of our Holding Hope groups established all across Canada. And of course, we have numerous ones that are in process of getting up and going. And so we have lots of goodness going on, and so much growth has taken place over, I'll say, the last 3 years for sure. So today our format is going to be where we're going to give Dr. Saah about 40 minutes to present. During that time, if you have any questions, pop them into the chat window and I'll make sure that they get funneled through accordingly so they can be answered. And and even when we do start taking questions, if something comes to mind, please don't hesitate to throw it into the chat window and we'll make sure that it is answered. And yeah, so I guess anything from there, if there's no questions at this point in time, we're going to keep going. And I'm going to introduce someone that we know is definitely a powerhouse in everything she does. One of our co-founders, former board chair and such for Mom Stop the Harm, Petra Schultz. I'm going to turn it over to you.
Thank you, Tyla, and so pleased to be with everyone this morning. I'm going to briefly provide a land acknowledgement before I introduce Rebecca. I'm an uninvited guest in Misquachis, Waskahikan, which is colonially known as Edmonton. It's a Treaty 6 and Métis Region 4. And the Edmonton, the middle of Edmonton is the North Saskatchewan River, and it's a meeting point and was a trading point for many Indigenous people. It is home to the Cree or Nehi, the Blackfoot, the Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Anishinaabe, and many others. We consider all of us treaty people, and what this means, an Indigenous person recently explained, is that to show respect and to make your land acknowledgement meaningful, think of the land you're on like it's your mother's house. Treat it like you're in your mother's house, and behave like you're in your mother's house, and treat the people like they're your mother. To me, reconciliation is undeniably tied to the war on drugs and the disproportionate way in which Indigenous people are affected. Here in the province of Alberta, Indigenous people are 7 times more likely to die from drug poisoning than settlers, which is stunning. Too many people are dying, and if we want to be truthful about reconciliation, and if we want to treat this place like our mother's this house, we have to stop the way the war on drugs is. We have to stop the war on drugs and end the way it's affecting Indigenous people. So thank you, everyone. As many of you have already done so. If you like, please put a little intro in the chat. And if you want to say, provide a little land acknowledgement, feel free to do so. Yeah, it's a pleasure for me to introduce Rebecca, Dr. Rebecca Haines-Saah. She's an associate professor in the Department of Health Sciences at the Cummings School of Medicine in Calgary, the University of Calgary. She's a public health sociologist, a PhD in behavioral health sciences and addiction studies from the University of Toronto. She's interested in public health and harm reduction approaches to substance use and drug policy reform. And recent projects includes the way cannabis, young people and cannabis use and opioid use and the family context of substance use, which is what we're talking about today, as well as projects we worked on together, which is a parent advocacy and Canada's overdose deaths emergency. Some of you might also know, if I can say this, might know Rebecca as Kathleen from Drawing Blank You'll Save TV show that we all watched. I have one of these middle-aged moments.
Degrassi.
Degrassi Junior High, Kathleen from Degrassi. But I know Rebecca as a dear friend. We've worked together now for 6 years on research around mothers advocacy. And through this time, Rebecca is always available to answer complex and complicated questions, because as an organization, we are evidence driven, we are research driven, and knowing researchers makes it all the more easy to find the right kind of information when we are looking for it. As part of our research project, Rebecca, together with her team and another team member, Heather Morris, has joined us this morning, Dr. Heather Morris now. We've worked all together on what's called a knowledge translation project, which is to take our findings, put them into action. And I'll pop a website into the chat, the See Beyond project, which shows how real people are affected by the crisis, including when Rebecca was really had a lot of time on her hand during COVID. She put together 1,000 statements of how families describe their loved ones that they lost, and it's just really, really powerful. So I'm so pleased to have Rebecca here, and yeah, take it away, Rebecca. Excited to hear you talk and the questions everyone has. Thank you so much.
Thank you so much for that introduction, Petra. I am so honored to be here and so grateful that so many of you showed up on a Sunday morning or afternoon to talk about this topic, which is something I never get tired of talking about. And I'm doing this presentation in many different venues. So I'm hoping to get some questions and some dialogue at the end. And I have some slides that will hopefully motivate us to be able to do that. And it's just wonderful to see all of you and to see people I've worked with in the past and present on the call. I'm just going to share my slides. I also want to say in a not patronizing way that I believe that people with lived experience, including families and friends, have the equivalent of PhDs in drug policy knowledge. And I always say that to Petra because I learned so much from all of you. And the science that I'm doing is worthless if it doesn't resonate and it can't be understood and taken up by families and communities. So that's how I approach things. So here's just the title, and I wanted to just make it explicit that I am talking about youth and young people, and because most drug initiation experimentation starts before 18. So that's kind of the demographic I'm talking about, but what I'm sharing has implications for the spectrum of youth and young adults. Some definitions of young adults go up to age 35. So there's a broad spectrum from about age 12 to 35. That's the population we're talking about today. Okay, so this was on the registration flyer, but I want you to kind of wipe your mind clean and forget everything you think you know about teens and drug use. As we were just talking while we were waiting to join about some of the things that are in the media right now, and we all have a lot of things about how we can protect kids or what should be done or what's not being done. And a lot of those things are not really based in what the evidence actually tells us. But I think how I always like to start is to remind people that we're all coming from a good place. We have ideas about young people and substances. We all want the best outcomes for kids. Sometimes, depending on our lived experience or our discipline or our research perspective, we differ on how we're going to get there. But that's the ultimate goal, is that we want to keep young people safer. So just a quick outline so you know where I'm going today in this talk. There's 3 P's. First, I'm going to talk about prevalence. So I'm a population health, public health scientist. So I'm always going to give you that broad view of what's happening for the population. I think that's really helpful to know what the recent numbers tell us. What exactly are young people using broadly across Canada? The paradoxes, the things we've tried to do and the things we get wrong in the messaging to young people. And then prevention. What does the evidence from the science actually show us about what works and what doesn't? I have a few caveats though. And the first one is, I don't think I need to do this for this particular group, but it's actually no judgment. And that is because as you're hearing things today, you may say, well, that's what I was taught in school, or yeah, I've actually told my kid that, or, you know, but I can't believe this isn't true, or, you know, there's no judgment if you've sort of adopted some of these approaches, because these messages about drugs, they're very morally and emotionally loaded when we're talking about educating young people. And I find myself, even as a parent now, as a teen and a preteen, that you know, it's hard sometimes to walk the talk. I know these things from the science, but when you're faced with it in your daily life, sometimes it can be challenging, right? There's no surprise there. I'm also taking a public health approach. So I'm going to be talking about interventions and perspectives on education and policy that broadly benefit most people in the population. This is not the intensive approach to addiction treatment downstream for people who need more intense supports. For me, public health approaches embrace harm reduction that can benefit the population level, but that's just the lens that I'm approaching it today. And that's a little bit different from perspectives of other types of scientists. And then finally, I'm not a clinician in any sense. I'm behavioral health science doesn't mean I'm trained in psychology or counseling or anything like that. And I'm also not a parenting expert. I think that's important to remind people, because I talk a little bit about what we know from the science and how we can communicate that to our loved ones, be they, you know, our children, our grandchildren, and young people in our communities. But I'm actually not officially an expert in parenting, although I try. Okay, so here's our first signpost as we move into the content. As we're looking at the numbers, I think it's important to remember that preventing experimentation isn't a realistic goal, right? So I think sometimes when we're thinking about youth substance use, some folks are hoping it's 0. But if you look at what's happening in the population, young people are using a range of substances across the ages of, we're going to start around grade 7 to grade 12. This type of experimentation happens. Average age for a lot of this is around, you know, age 14. So if people are going to experiment, it happens young, and preventing that completely isn't necessarily where we need to put our efforts, and I'll show you why. I'll start with a good news story, because this was my first area of research in working with youth, and that's tobacco. When I started my PhD in the late 90s, there was a ton of money being thrown at me to research young women and smoking, because teenage girls had a smoking rate that was almost 30%, which is a very high prevalence of tobacco use for young people. And all of a sudden, young women were smoking more than young men. And that led to a big panic among policymakers and researchers. It was very gendered. You know, oh, young girls, what they're smoking, what's happening? And so over time, with tobacco control measures at the population level, that's what's mostly been effective at reducing teen smoking. So it's not going into schools and telling young people not to smoke, and a lot of horrible stuff that I looked at in my early research, where they told young women you're going to be ugly and wrinkly if you smoke. And they told young men, if you smoke, you'll have erectile dysfunction. Like, This type of messaging was really stigmatizing and ridiculous, and it didn't really resonate with teens. But what did drive down youth tobacco rates was taxation, restrictions on where you can smoke cigarettes, the price of cigarettes, and those broad population level measures, right? So you can see over time now, current smokers, including occasional smokers and daily smokers, that's only a 2% prevalence in Canada, and that's really low. So we've had a success story by intervening at the population level. However, at the same time, we know that drug markets expand and respond a lot quicker than we can in public health. And so vaping, of course, initially, pitched as a type of harm reduction measure for cigarettes, and there may be some merit to that for older people who are chronic, continuous smokers and who may not ever quit. But for young people, not so much a harm reduction measure, maybe entrenching, nicotine addiction early on, which is, not a great pathway for young people in adolescence. So you can see that, vaping in many regions has replaced cigarette use among young people, and it's in every school and in every region. But I think it's important to remember, we've been talking a lot about cannabis and other substances, vaping, but alcohol is still the number1 substance used by young people. And high risk drinking, which we formerly called binge drinking, is also, a quarter, 23% of kids in the previous reporting cycle for the survey, then down to 21. I mean, that's not really a significant reduction. We're seeing people use also energy drinks that have alcohol. So mixing, some are available in stores, or mixing like Red Bull with vodka, that type of thing is very common. I should have mentioned at the beginning when I started, sorry, I was so excited to dive into the data. This is from Health Canada, Statistics Canada. It's known as the Canadian Student Tobacco, Alcohol and Drug Use Survey. It's done every 2 years. So the last one we have is 2021-22. They took this data offline, but I got access to it through another route because there was a tiny statistical error. So some of these numbers may be slightly adjusted, but this is pretty much the story from the last cycle to this cycle. So you can see what's happening with alcohol. This is also a good news story. If you remember, in the lead up to cannabis legalization, the Canadian Medical Association, the Canadian Pediatric Association issued statements saying legalization is a threat to youth health. We should not enact this policy, totally ignoring the fact that youth were being criminalized for their use and the legal and social consequences of having a criminal record, whether you're under 18 or whether you're a young adult, and also when you're a parent. But the sky didn't fall. Youth prevalence really didn't change that much. It stayed stable around 17-18%. That was pre-legalization. So basically, youth who wanted to access cannabis in the illegal market may be continuing to do so, or they may be having diverted cannabis from the legal market. But legalization, that policy change, didn't change the picture of youth prevalence. And that is a good news story, because that's not the case in every jurisdiction. Okay, this slide is really busy, but this is how it's presented. And I think it's also important to see. 7% of young people report consuming 1 or more illegal drugs in the past 12 months. And when you look at the top drugs that young people are consuming, that's hallucinogenic drugs, synthetic cannabinoids, which are really dangerous compared to cannabis. They have no plant material. And this is another way that the illegal market has responded. So one of the reasons that synthetic cannabinoids came about is because they don't show up in the cannabis drug testing for workplace testing. So they're a synthetic variation, and it has been cut with a bunch of different things. So very, very dangerous and really high potency and can lead to psychosis. And then also cocaine. These are the drugs that young people tend to use. But you can see these percentages are much smaller. I want to add a caveat here that this is a school-based survey. So this is at the broad population level. This is what people in grades 7 to 12 are reporting when they're given a survey in school. So it may not totally reflect what's happening in the population, and of course doesn't reflect disenfranchised youth not attending school, and youth who, you know, are unhoused and, you know, wouldn't be captured in the survey. So this is just what's happening broadly at the population level if you look across Canada. If we look at medications, youth are accessing prescription meds that are diverted, but also over-the-counter medications, seeking out intoxication, right, to get high. So not for their intended prescribed use in many cases. So here in the past year use, we'll see that the categories of like pharmaceuticals and stimulants, those are sort of like broad parent categories. But the things that people access are over here. They're accessing cough syrup medicine. They're accessing Gravol, the stomach nausea medication. And they're also accessing some pain relievers and stimulants, and sometimes ADHD medicines that they're getting, you know, from friends and family. So these are the types of substances that young people will say that they're using when you ask them in a school-based survey. Of course, beyond that, I think it's important to get a full picture of what's happening with young people in the population, to also look at where problems are showing up, not just on reported prevalence of use, because prevalence is, you know, necessary but not sufficient for harm. So while many young people in that survey are reporting that they're using substances for social reasons and to relax and for experimentation or just to see what it's like, young people do experience harms and problems. So this is the population rates of per 100,000 across the provinces and territories. And this is a bit older data, but it's the latest we have from CIHI, which is another Canadian health information and reporting group. And I think it's, you know, it's a little bit tricky. I don't want to create a moral panic, but it is a bit, you know, of an issue to see that 1 out of every 20 hospital stays among youth 10 to 24 was related to substance use, with the, you know, knowledge that substance use may be only part of the reason they've shown up there. And most young people who are showing up for substance use are also there because they have a co-occurring mental health issue, right? So these things very much overlap. But you can see, for example, where I am, you know, it's alcohol and cannabis. Alcohol is 156 per 100,000, cannabis 155, right? So not as high as some regions and territories in the north or rural regions. You see higher presentations. So that tells you that how things are distributed, how harms are distributed, what's happening in that region when we see peaks of higher problems, has a lot to do with a lack of opportunity for young people, for recreation, and for community support. And that's something I'm going to talk about in a little bit when we look at what works in prevention. For this audience and for everyone, I don't think we can talk about what's happening with young people and substances without being really clear that we are in a public health emergency. And I know I don't have to tell a mom stop the harm, stronger together, Hope Connects argument, audience. I don't have to convince you of this argument. So this is from the Canadian Pediatric Surveillance Group, and they just released this in the fall. And, you know, it coincided with some data from the BC coroner for that region. So largely because of what's happening in BC, but also in other parts of Western Canada, drug poisoning is the leading cause of death for 10 to 18-year-olds. And we're seeing, you know, the data from FACT showing 2% of overdose deaths and 5% of overdose hospitalizations in Canada are for young people under 19. And these are young people that had, you know, health contact with providers just prior to their deaths, and many young people in care. So this is really a missed opportunity and a need for more services downstream for young people and upstream. I'm going to pivot now. I've bombarded you with statistics, but my idea was to give you just a broad sense of what's happening in the population. Because sometimes when I do community presentations, and on the road to cannabis legalization, I did so many, people will say, well, I thought that 90% of young people use cannabis, not really realizing it's below 20, and forgetting that the most frequently used substances are nicotine and alcohol. So I've given you that broad knowledge. Now I want to focus on messaging. And our big signpost here is we need to say no. We need to say no to what we've done when we're basing our messages on fear, when we're basing our messages on stigmatizing drug use. This is unrealistic and unsupportive for young people, and we need to find a better way. Okay, so if you grew up in the 80s, I will fully admit I'm 51. So in the 80s, it was like the peak of war on drugs propaganda. You may remember this ad. Crack the egg into the pan. This is your brain. This is drugs. This is your brain on drugs. Any questions? That was literally how the ad on the TV show went. But what's the paradox for this? When we tell young people that drug use fries your brain, drugs really impact your brain. I'll tell you what people said when I was in school and what we find that youth still say. Oh, this is strong. The drugs change my brain. Drugs to put into youth terms, drugs really screw you up. Okay, sign me up. This is not all youth, but some youth are looking for experimentation. It's a natural part of adolescence. They're looking for risk. They're looking for pleasure. They're looking to try new things. And this is the age when it happens. So this type of messaging really backfires. I always say just say no works for some of the kids some of the time. Those inclined to follow rules, those who are anxious, those who are more cautious. And I know because I have one of each type of kid at home. I have a cautious kid and I have a risk taker, right? But it does a huge disservice to those kids who are going to experiment. If we just tell you don't do drugs, they fry your brain, what are you left with? How can you stay safe? Here's a second drug education paradox known as the drug suitcase. I am being so serious that this was a major intervention. It was something for purchase that was sold, that was used in many schools, often, done by police or other adult authority figures. You have all the different drugs here and how they appear and the paraphernalia and accessories for using them. Well, what is the paradox here? What do you think happens when you go into a junior high or an early high school and show young people a bunch of different substances, when you bombard them with information? A young person is like, oh, I just thought there was alcohol and opiates. I didn't know there are hallucinogens. That seems kind of interesting. Maybe I'll go look for those, right? So giving young people lots of information about different substances is not necessarily an effective prevention or education strategy. The other paradox is that as we get older, we forget that youth are an entirely different culture. They have a different language, they have different values, they're oriented to the present. They're not necessarily, and this is not for all youth, but they're not necessarily oriented to longer term consequences. But especially in tobacco, we try to preach to young people that one day you'll get lung cancer, right? This doesn't resonate. Youth will say in surveys and in qualitative work where you ask them, I do not care about those consequences, right? That's going to happen to me one day. Not all youth, but a portion of youth, right? I use this example here because it's in French, but it's from the Quebec Psychiatric Society. And you'll see here that they have an eggplant. Eggplant doesn't mean for youth what they're thinking it means here. They're saying, like, if you smoke cannabis, you'll be a lazy eggplant. If you have a young person in your life, you'll know that eggplant emoji means something entirely different, right? So they got it really wrong here. I'm sorry if you're from Leduc, but Leduc put out this silly cannabis prevention program for youth, which had Buddy He's like a cannabis police officer, cannabis plant. And they had to pull this because people were like, this is silly. Why are you talking to young people like cannabis is a cartoon cop? It doesn't make any sense. Then down here, we have this campaign from Alberta, the government of Alberta, the Ministry of Health. The previous government put this out in 2016. It's about impaired driving. They spent $165,000 to put this on social media. And to me, you know, on one side, you see a young person in a convertible. I mean, how many people drive convertibles in Alberta to begin with? They've got a beer and then they've got a joint. But if I'm 15, what does this look like? This is like, I am glamorous, I am cool, and I am smoking weed and drinking in the car with my friends. There's no prevention message here that can resonate about how to stay safer. It doesn't say like, hey, if you've smoked weed, please don't drive for 4 to 6 hours because you're still going to be impaired. So it's just like, to me, a total waste of money and time. And I got myself into a little trouble for saying that in the Globe and Mail, but that's okay. I'm sorry, you know, this slide is graphic, and you know, you may just want to not look at it. I won't keep it up too long, but I have to include it because we've done some really awful, horrible, unethical stuff in messaging young people. Especially this slide up here in the top right corner. This is from the major non-smoking rights group in France, and the message was like, "Fumer, c'est être un slave du tabac," which is like, if you smoke, you're a slave. And the Minister of Health in France actually said, young people do not understand health consequences. Okay, that's true. What they understand is exploitation, especially sexual exploitation. So, you know, they're making it here like someone is forced to perform oral sex. Really disgusting, violent messaging that we only think is acceptable for young people. Also around methamphetamine, some campaigns from Health Canada, Drugs Not For Me. It's an incredibly ridiculously stigmatizing video that came out in the mid-2000s. And now we're doing the same with vaping. You know, we're telling young people that they're victims of an epidemic and they're going to have lung damage and facial damage from vaping, right? So quite what I would call violent messaging towards young people. This is another place where we get it wrong in thinking about prevention. And you can see I'm really passionate about this because we do a lot of crappy stuff. Okay. So a lot of text on this slide, but I want to just give a little bit of hope after I've been so critical, right? What should our approach be if we're going to do this type of education, if we're going to do something? Now, if you gave me $1 million, I would not do a campaign. I would invest in a community and a program for young people. But if we're going to do drug education, what should we do? And especially for young people, I believe and support harm reduction, but I don't use the words harm reduction for younger kids because this triggers a lot of debate and divisiveness. So I talk about a term that was developed by the Drug Policy Alliance back in 2014. They call it abstinence plus. This is an appropriate way to talk about it for the under 12 set, right? Or safety first, which is how they've rebranded this program that they started back then. So we're providing honest, science-based information. We're going to encourage moderation if experimentation persists. Educating young folks that there's legal and social consequences, not just on the health consequences. They need to know what the local laws are. And, you know, this really affects people from marginalized communities that may be over-policed even more. Understanding the social context, so where you're using the substance, this classic harm reduction concept of set and setting. And looking at, you know, personal responsibility, safety, and knowledge. We can do all this for young people in our messaging, but at the same time, we need broader community supports. But this is just, you know, what I think should be done if we are going to do some type of education in the schools or as a public health campaign. And delaying. I think it's one place where it's appropriate not to talk about abstinence per se, like never use. I don't think that's realistic. But telling the young people in your life, delay as long as possible, or delay into regular use as long as possible. This can be helpful for preventing, you know, trajectories into problematic use. Okay, so here's my other signpost now, as we're going to talk a little bit about prevention science, and that is that the best prevention has very little to do with drugs. This is the final chapter. Okay. These have been the things that have informed most prevention in North America. And here on the left, you see Nancy Reagan, the wife of the former President Ronald Reagan. Just say no. A lot of folks don't know that the youth anti-drug slogan, just say no, came directly from Nancy Reagan, and her spouse being, the architect of the war on drugs policy, one of them, right, in the 80s and the crackdowns. She was leaving some event. They said, like, what would you tell young people who are going to use drugs? Just say no. And this kind of launched this whole approach. And then also DARE, Drug Abuse Resistance Education, a major program delivered by police, still delivered in Alberta in some areas, still delivered and being redeveloped in North America and Europe. The evaluations of DARE over time showed that they did very little to reduce substance use. Even though young people may have shown a little bit of knowledge and awareness of substances. One of the other problems that people, of course, have raised is that DARE is delivered by police. Police are not trusted sources of information for many young people. And also, being a racialized person, having a police officer in your school, or being a person whose family there might be substance use, not a safe person for everyone, right? So there's also been a push to have, uniformed cops not deliver the drug education to young people. That might not be the best point of contact. So these are values that we've had inform our prevention science, not necessarily evidence, unfortunately. Okay. So in a nutshell, what works? What are the things that do work? Rebecca, you're being so negative. Everything's horrible. We waste all our time and money doing things that aren't effective. Can you tell us some good news about what works? I'm here to tell you these are things that are not necessarily specific to drugs. And these are interventions that are not necessarily where I focus at the population level in terms of policy, but we can do these things at the school level, at the meso level, at the interactive level, that really support teens in doing better. These are psychosocial and developmental interventions. Some of my colleagues are piloting these. There's a large trial running the Preventure and the Univenture trials. These are very expensive and costly, but they show some good outcomes. So rather than bombarding youth with facts in school and saying, here's everything about cannabis, here's everything about alcohol, here's everything about painkillers, other drugs that you may be exposed to, these interventions kind of work with the young person's personality. They do a little bit of inventory and typing, which not every young person might want to do, but the type of scales we do when we're being assessed for depression or anxiety. And they say, well, this young person is more inclined to take risks. They're more of an experimenter. Here's the type of education and supports they would need around learning around substances. This young person does not take risks. So we're going to approach the intervention this way. So this type of thing sort of differentiates. It's away from universal to personality typing. This has shown good outcomes. This is very costly. It's not necessarily something I would want to do in schools, but it's effective. The other thing that's effective is social emotional learning. If you heard about mental health promotion, this may be familiar to you. Resilience is one word that's associated with it, but we have some interventions in schools called the good behavior game. There's some family-based interventions. All of these things are kind of fun and light, and they teach young people skills for coping, for dealing with conflict in peer groups with friends. These things apply not only to substances, but other risk behaviors around self-harm, around sexual risk taking, and also around bullying, right? So bolstering the young person's skills and coping can also help. I'm also just a tiny bit skeptical of this because there's only so much you can do to help people cope if the context around them is really crappy, if they're living in poverty, if they're experiencing racism and other things. But this is one thing we can do rather than just give them, an hour lecture about drug information. And then finally, just like a really quick thing you can do that's actually effective is what I've done here today in my first portion. Because a few people in their peer group are using, young people sometimes believe that everybody's drinking. So I did show that drinking was fairly high, like almost 50%. You can say, hey, like half of your friends are not actually drinking, or half of people your age aren't drinking. And for younger teens, this seems to have a positive impact. Like, oh, okay, you know, if I don't drink, you know, it's, you know, that's about what other folks are doing, and I'm not going to be sort of excluded. It's normal not to drink as well. Okay, and this is a final graph I have for you. But if you work in prevention science, this is something that people got so excited about. And this is known as the Icelandic model, or Planet Youth. Now, this is pretty hard to replicate what they did in Iceland in other contexts, but I'll just give you like the rundown. They had very high rates of alcohol use and tobacco use, up to 42%, like what we have in some areas, you know, for alcohol, 23% for smoking. They have very long, dark winters. And they managed over time to reduce these rates down. They have them within, you know, 10 years of the intervention. As you can see, as you go across this chart, they've gone down even lower. And they have hashish there, which I guess is a substance more used in Iceland. But they really focused on the drop in alcohol and cigarette use. What they did was not education. They provided free recreation and in sport and arts to all youth and families. So they opened up community centers, they opened up sport programs, outdoor sports, skiing, all free for everyone. They had parent support groups, had good uptake. That wasn't as much of the deciding variable. They also did something that I don't think would fly now, but it worked for them then, which was they had a youth curfew as well. So a little bit heavy-handed, a little bit of policing what youth were doing, but they were looking for ways to strengthen community ties, and they managed to do that. So this model's been piloted in Canada. We don't yet have the outcomes, but there's a few places that are trying it in small jurisdictions. Of course, it can't be a national project because we have a very diverse terrain and a very diverse population. Okay. To further my point that it's what we do at the community level that prevents problematic use for the population, here's just a chart, a little graph that illustrates this. This is from Teresa Tam's report on problematic substance use that we worked on right before the pandemic. And so at the top of the pyramid, you see those intense interventions for young people who are struggling. And then as you move down, you see what can we do at each level to improve outcomes and have fewer youth transitioning into problematic youth. And at the bottom, we have those things I was referring to. When we have more stable and equitable societies, less racism, less poverty, less homophobia, discrimination, bullying, economic opportunities for everyone, this creates the foundation. So that's really the population level public health approach of strengthening communities and not blaming the individuals and families when they're using substances for coping. And we can talk more about that later. I just want to move on though, because I know I'm getting to my time. Okay, so in summary, here's a little slide that's handy of some of the things I've just said in prevention. What if you want to apply this to your conversations with people, to the people you care about, to the young people in your lives, or just those discussions you have in the community when people say, you know, what should we do? What is the way forward to address these problems? Just say no doesn't work, right? Open communication, trust, and respect. Modeling responsible uses of substances for young people, talking to them openly about what responsible use looks like for you. Not, this is your brain on drugs, drugs fry your brain. They're not going, that's not, especially not going to resonate with youth when they see that their parents, caregivers, and other people in their home and community are using drugs. And I'm including alcohol here, cannabis, and everyday drugs and other drugs that people are using. Telling young people, don't do drugs. Drugs aren't cool. This is a very adult-centric model. We need to support people in those coping skills, that social emotional learning. Instead of a big bombardment with a single session of, oh, here's everything you need to know about vaping, really a whole school and community-based approach. Alberta Health Services, where I am, has an app for this now that they do with young people. They don't do as much of the single substance education because they found that this just increases use of some substances. people have been reluctant to do this, but I firmly believe in peer-led programs and peer support, that young people, that youth, that older youth can teach young people, that young people are more likely to listen and feel supportive when we have peer-based discussions and leadership. You know this because this is what you're doing in Holding Hope and Healing Hearts. And then rather than having programs delivered by police officers, we can do these tailored interventions. So these are some things, what works and what doesn't. I like to provide people with, you know, some inspiration, because there's been so much that has been really, really bad in this area. And here's a slide I've done for people. I did this for parents when I go into schools. It's a little bit of a different audience because everyone there has a young person in their life. But here are, again, some of those myths, fears, and facts, and some statements to kind of counteract these. So I thought I would include this here because it could spark some discussion, or you may want to harken back to any of those slides that I've included. But I guess this is a really great point just to open it up and take some questions.
Okay. Lots here. Thank you, Rebecca. I've been making some of my own notes. It just, you know, it's quite interesting that I'm saying that, you know, from what you're saying and what you're sharing, is that sometimes over giving youth information actually works contrary to what we're hoping for, right? So that's really interesting. There's some questions in the chat. I just wanted to ask a couple of questions first. In the earlier slides, when you mentioned about cannabis laced with, oh no, sorry. What is a synthetic cannabinoid? Like, what is that actually?
Right, it's like a lab formulated version of cannabis that is meant to give you a type of high. You may hear like there's different names like spice or different, like it hasn't really infiltrated into Canada, but we saw a rash of poisoning deaths from it in New Jersey because I think it was cut with rat poison. But it is a synthetic type of cannabis. It has nothing to do with the plant. So it's, you know, the chemical compounds have been replicated in the lab. And like I said, it was developed mainly because people wanted to use cannabis, but they wanted to avoid drug testing. So in the illicit market, this alternative came up. Yeah, and it's quite dangerous.
Thank you. You also use the phrase diverted. What do you mean by diversion or diverted?
Sure. I mean, well, all substances that youth access are diverted for the most part, unless they may have a prescription for something. But when young people are, in those slides that I showed, where young people are accessing, you know, medications, most of this is diverted from friends and family, including alcohol, right? So the main source of alcohol for young people is through parents. And often that's parents giving, but also that's young people just taking alcohol that their parents have in the house. So diversion is a kind of a politicized word right now when we hear about it being used in the context of young people accessing diverted, so safe supply. But this is how all young people access cannabis, basically, and alcohol and other drugs that they're first likely to access.
Thank you. Okay, so the questions in the chat that Tyla's sent to me directly is, stats are gendered. Are there stats for other factors such as family income, family structure, i.e. single parent families, public or private home, or unschooled? These stats might prove interesting if they are done.
Yeah, that's a great question. And I think what you're getting at is what we look at in population health. And that's how, you know, broad population level factors like income, education, family composition, those types of things would really impact substance use outcomes. We know that people across the spectrum of the population use substances, but if you want to talk about broad level trends, you know, people who have less, who have greater stressors, experience more problematic use. And that's simply because whether it's a person or family, they have less access to resources to respond to the problems that substance use creates. So if I have more money, I can purchase more therapy. You know, I can purchase interventions, but also I may, if I have more money, it might be because I'm in a job where I have more freedom and more flexibility to attend these sessions, to take time off. I have benefits and I have supports. So it's kind of a web of either supports or detractors, right? So that's how we think about it. You know, there is definitely a relationship between people experiencing problems and what their family or community context looks like.
Thank you. Thank you. That makes a lot of sense. The next question, and we might need a little bit more from the person that asked it.
Yeah.
What does harm cause mean exactly in this content? So I'm not sure when that question came through. And the person that asked it, would you like to unmute and maybe give a little bit more context so that Rebecca can respond?
Sure, it's Samantha. So in your earlier slides, when you were talking about statistics, you mentioned something about hospitalizations among youth due to harms caused from substances. So I was just curious what that means. Is it because they've had poisonings? Maybe they're in psychosis or,
Yeah. So that CAI study that I referenced doesn't necessarily break it down. When we've done a similar study here in Alberta, looking at young people's hospitalizations pre-post, they will include those codes, you know, for like an episode of psychosis, not necessarily like they're having a diagnosis of schizophrenia, but episodic psychosis from high intensity cannabis use, sometimes paranoia and anxiety. Sometimes cannabis use is coded as one of the problems when they're showing up because they're having, you know, anxiety and panic. That's the problem, but also they're coded for cannabis use and alcohol. So that's the caveat about that CAI data, is that there can be more than one thing going on. But hospitalization data is just another way that we look across the population to say, like, who's having problems and who's showing up, right? But you're right, those harms for cannabis and alcohol are not necessarily what we'd think of as overdose or you know, morbidity. They're just showing up and being coded for that problem.
Dr. Saw, I'm just wondering, could you maybe stop screen sharing and then we can see you more so, and now that we're in conversation.
Yeah.
Thank
you.
Okay. And when you shifted that, it shifted all of my, I'm sorry, it shifted my, my questions. So I'm going to have to take a second and okay. Okay. The next question is, you use the term, overdose deaths, but the language that Mom Stop the Harm uses is accidental poisoning. Can you explain why you would use language as overdose deaths versus accidental poisoning?
Oh yeah, I'm sorry for that. And of course, I have worked with Mom Stop to Harm for a while, and the language has changed over time. And so this is just because in some of the reports, that's how they're still using it at the federal level. So we say accidental poisoning or overdose or toxic supply deaths. Like, I see the terms as somewhat interchangeable, but I don't intend to be disrespectful. I totally agree with the Mom Stop the Harm language.
Mm-hmm. And I'll jump in here a little bit. I know for a lot of the people that I've spoken to, when we use the term overdose, that there's a misconception that people intentionally took too much of a substance. And so then it causes stigma, and it just causes a lot of other misinformation. So I've run into that quite a bit.
Yeah.
Okay, is there any news on whether prevention could be more widely adopted and and the cost subsidized?
Yeah, I mean, this is one thing that the swap funding, such as, you know, the funding that funds this initiative is meant to do in communities, right? We have some pockets of money when communities want to implement programs to support young people. And I agree that, you know, we should be doing better prevention provincially. We should have more funding for this, and we should have more funding for youth harm reduction, right? To respond on the ground for better education and supports for young people who need it. But in some arenas, youth use is politicized in the same way, and we're going to only focus on treatment or abstinence-based education, and it's actually incredibly hard to get interventions and research into schools. That's one of the big barriers. So it's always kind of been a stumbling block. That is why I say I feel we should have more supports in communities.
Very true. Can you give us the link to the app you mentioned that Alberta Health Services maybe directed?
Yes, hold on one sec. I can do also like a follow-up. Let me see if I can quickly find it, but I can also do a follow-up handout with some of the things and places that I can't find it right now. It's okay, it's not coming up in my search. But I will send a little follow-up you can send out, Antoinette, to everyone who registered.
Perfect, thank you. And I noticed in the chat there was some other you know, websites being referenced and supported. So maybe we could get those, and we will put those all together when we send out the recording to everybody so that you'll have those.
Oh, I see something from Emily about Planet Youth, so I'll just respond to that quickly. I don't have concerns about Planet Youth per se. I think it's a great community-based program, and I would encourage you to participate and find out what it's about. My only hesitation, as I said, is Iceland's really different from Canada, so I'm wondering if it's going to be able to be adapted here, and maybe it will be.
Okay, going back to the questions, are you aware of any research that examines the relationship between problematic substance use and/or death from substance use and the schooling experience, especially among people who have been diagnosed with behavioral disorders such as ADHD?
Sorry, can you just repeat that last part? I got a little bit distracted by the chat. Sorry.
Yeah, if you want to, I've got all the questions and what.
Yeah, sorry, I was trying to follow along.
Okay.
So intervention specifically for young people with ADHD around substance use.
Are you aware of any research that examines the relationship between problematic substance use and death from substance use, and the schooling experience, especially around young people that have been diagnosed with behavioral disorders such as ADHD?
Yeah, I'm going to answer this question in two ways. One is for cannabis use. You know, there was a lot of concern about this when we were legalizing, but we haven't been able to see, looking across reviews of studies, any predictive relationship between, you know, having ADHD and transitioning into drugs. It's not the predictive factor per se, and that kind of like made people a little more confident that this population wouldn't be affected, although people assumed that. What I'll say is not based on statistics or interventions, but it is based on the research project that we did with Mom Stop the Harm, where we spoke to 43 people whose children had died across Canada. And that is, I think, you know, and the range of the time when people died was, you know, dating back to, let's say, like the past decade or so, and some more recent. And we started that project in 2018. Many people shared that young people in their lives, their kids, use substances because they experience difficulties in school with bullying, with problems with emotions, problem with learning. But one thing we heard frequently is, you know, they had anxiety or, you know, early on we could see something, and then it turned out they were using substances as a way to feel better. Because going back, we had no language to talk about mental health and well-being and emotional struggles. So I think that is one thing for Gen Z now that has shifted. But I would definitely say if we were to look back over time and do this prospective study, we could see that change, right? So that's from the qualitative evidence, but I mean, we heard it repeatedly. From, you know, my young person, that they probably had anxiety but were never diagnosed. They probably had learning problems but were never diagnosed. We didn't know until, you know, they started using substances that this had come up. This is not to blame families or parents. I think we just have a different conversation now with our young people.
Absolutely. So then there was another piece with that is, what are we asking governments, federal and provincial governments, to do? And can you translate all of that into a policy?
Yeah, it's incredibly tricky to translate things into policy, and people sometimes leave from this saying, you know, oh well, please tell me what to do, Rebecca. Like, you know, you're just telling me to end inequality and that will end problematic substance use. It seems really kind of high in the sky. Where I usually land is saying, I know what we shouldn't do more than I know what we should do. So I know where we shouldn't put our money. And that's in this kind of like didactic, one-way education, or in a lot of posters, or in a lot of pamphlets. And we definitely shouldn't do things that don't resonate with young people, right? They should be driven by youth. So that's where I know our policies are going to go wrong. I don't always know where the policy will go right because we haven't done this in many instances.
I really like when you say that about just not one way in targeting. And it's the same thing we talk about with adults that are struggling and have struggling with substances, is one size does not fit all. And I
Yes.
think that's the same thing that you're saying for the youth, and we need to take that into consideration when we're looking at what are we going to do and how are we going to do it. So
Right.
and then asking them, the experts, as we do, you know, with adults.
Exactly. Yeah.
Do you have any recommendations for how to depoliticize the conversation around substance use and safe supply?
Yeah, when it comes to young people, I mean, this is a big question. Personally, sometimes I say, you know, there's a lot of emphasis on protecting kids. You know, that kids are at risk, and that kids are getting diverted drugs. And I think I'm not sure yet because I haven't tried it with a policymaker audience, but the idea that you know, youth get access to a lot of different substances, not just safe supply. And the one they're most at risk at actually is from alcohol. Like if you want to look at hospitalization data, if you want to look at the link between, you know, initiating use and having problems, and also risk of harm from self-injury, assault, you know, driving. Alcohol is probably the riskiest drug. You know, so we need to have conversations with young people openly about harm reduction, about staying safe, about who to call, you know, when you have a problem. We don't demonize families and communities saying like, oh, we're going to like make alcohol, we're going to bring back prohibition and make alcohol illegal, you know, because that drug is culturally acceptable and socially acceptable. So sometimes in harm reduction and drug policy, we use those types of examples, like those types of parallels. But I would say that anytime you hear a politician or community group saying we need to protect kids, like listen really closely, because often it's, I think, being weaponized to get at that moral value that young people, or that young people are innocent and we need to protect them. You know, this data shows you that young people are starting to use a range of substances in grade 7. So instead of protection, we need support, we need acceptance, and we need harm reduction to keep them safe and alive.
I am just going to read Sarah's last comment, only because I probably shouldn't have added the ADHD part. Just thinking about my son's experience after being diagnosed, I guess I'm questioning whether certain schooling experiences can be harmful and contribute to problematic substance use. And I have both my mom and my education research hat on.
Yeah, I think that's very valid, and I think it's important to raise ADHD. I mean, that's fine. I don't see a problem with that. It's a question that many people had around increased availability of cannabis legally to young people. If you look at that CSTADS data, they definitely show a link between prevalence of substances and self-reported experiences of poor mental health and also bullying. So, I mean, this isn't a population variable, but it's like a school culture variable. And I would say definitely that these things could be linked, like not having social support, not having friends, and not having ways of coping that don't involve substances. So, I mean, we do this as adults, and it just makes sense that if young people find something that helps them forget about the crappy things they're experiencing at school and makes them feel better for a little bit, that's a risk for going into more problematic use. So, Sarah, I think that those are very good questions, and those are things to think about. Families know the young person in their lives better than anyone, right? So you're looking at that kid, how they're doing in school. I'll just say that the reverse is true. Kids who are very pro-social and have a lot of friends, they can be the leaders and the risk takers. So those also can be the young people who are more likely to use substances. But are they using it for fun? Are they going to use it in a risky way? Are they going to use it for coping? Those are the things that we're thinking about. So basically, don't freak out if a young person tells you, well, I tried this. It's like, okay, let's keep the conversation open so we know how and when you're using.
Very true. You hear or often or in the news or in different places how cannabis has been laced with other drugs like heroin or fentanyl or methamphetamines. What would you comment to that?
Yeah, I mean, my high level reaction to that is, this is largely a myth that we've heard from many different powerful people, but it's not actually true that you can use these two substances together. So when we're talking about fentanyl specifically, so if it's happening, it's maybe like minor cross-contamination, but the burn rate of fentanyl is so much different from the burn rate of cannabis. And the way that you smoke cannabis in a joint versus the way you would smoke fentanyl with tinfoil and a pipe and a lighter, it's totally different. So you wouldn't be able to overdose even if it was a minor contamination. But the bigger point is that we think that politicians and police haven't come out and said, yes, we haven't seen evidence in toxicology, and yes, it's also impossible, because it's a way that we deter youth from using cannabis. And this is just another example of our shitty approach to prevention. Sorry for my language. We'd rather say things that are untrue if we think they're going to keep kids away from drugs than actually giving people the facts. And when you do this, you create a lot of mistrust in what we're hearing, right? And I think it's been one of the more dangerous myths.
Thank you. Right now, I'm not seeing any other questions that Tyla's sent to me through the chat. So I just wanted to see if there was any other questions that maybe got missed, or if, things have come up for people. And if we don't, we will be done a little bit earlier. I just wanted to open it up to see if it's other people had other questions that were kind of still ruminating. Just give it another minute. So
yeah, I mean, I would close and say I have 3 big safety tips. If you have a young person in your life, or say now, you're an auntie or a grandma and someone's coming to you wondering, Here are 3 practical things that I always close with when I'm going into schools. And that's ensure your child has a relationship with an adult they trust outside of the immediate family, someone other than you that they could go to, if they need extra support or someone to talk to. You encourage these relationships early on, and they can be protective around, I smoke cannabis at school. I don't know what to tell my mom or something like this. This is one thing I do in my home. And then the practical things of having a code word that a young person can use so they don't have to be embarrassed in front of their peers, an exit strategy so they can text you and call you and you can pick them up anytime or any place. I've done this for my young person, and we've done this for other young people in our lives, relatives of ours. And then I hope Mom Stop the Harm will know when I go into schools, I say that overdose or drug poisoning prevention is essential first aid for all families and for all young people. And so young people should know what it looks like. And when they do this first aid through St. John's and Red Cross in the schools they pilot, they use the word overdose. So I say, like, youth should know what this looks like. They should know how to respond. They should know about the Good Samaritan Act. They should know when to call 911, and they should know what an naloxone kit's like if you have it in your home. And since I have teenagers, my teenagers definitely know where the kits are and what they look like. So if I had a group of teenagers in my house and I wasn't home, my kids would know what to do. So those are the high level things that I share with all parents and families.
I'm just looking at, yes, there's a post that went around Facebook called X, where they accidentally text you the letter X and they can get out of there for free, no questions asked, so long as no harm or maybe cause. So I did that also with my kids. Said, if you needed me, just say, hey, Mom, I know you're coming to get me, pick me up because we have this or that going on. And that would be my cue. It's like, okay, they need out of the situation. So giving them, that connection time, I think, is so important.
Yeah.
Um,
We forget that what goes wrong for teens sometimes is when they don't have that soft place to land. Yeah. Oh, I see Petra's hand up.
yeah, Petra.
Yeah, Rebecca, one question I have, and that I often get: at what age should I start talking to my kid?
Yeah.
And the question of age appropriateness of delivering information, and of course that is also connected like to sex ed and safe drinking and those kind of things. Would maybe you can give us some of your thoughts on that as well?
Very much so. I'm a strong advocate for starting the conversations early at age 8 to 10. You need to start these conversations, and it also depends very much on the emotional maturity of the young person and what they're capable of understanding and what risks you think they might be taking and the type of relationship that you have. But just as we wouldn't have those conversations about sexual activity later because we want to have young people protected and knowing going in about certain parameters. Now, this has also become a very political conversation. So I used to be able to make this parallel. It doesn't really work anymore in some contexts, but 8 to 10 in age appropriate ways. And also, I think that's when those closest to the child, we need to think about what we're modeling around them and what they see among our friends, and having open conversations about that, right? When you see me drinking, this is what I'm doing. This is the limit I have for drinking for myself. These types of conversations. When I talk about age appropriate, I have a junior high school student. So before junior high, I talked to him a lot about binge drinking that young people might be doing, about vaping, about cannabis. And I also talked to him about pills and powders. I'm not shaming people, for a 17-year-old or an 18-year-old, maybe even a 15 or 16-year-old, we might talk more about naloxone and getting drugs tested and those things. I think for someone who's 12 to 13, it's very appropriate to say, hey, like no pills and powders. The unregulated drug supply right now is very dangerous and very toxic. And you're too young to know what you're getting or how to use that safely. So there are going to be other substances in your school. But if you're offered a pill or you're offered a powder, I really want you to stay away from that now. Now, that does seem like abstinence and just say no, but it is actually not if you're embedding it in a conversation like, hey, for example, my young person's told me it's been offered mushrooms, alcohol, vapes, and cannabis in grade 7, right? So, we're having that conversation about what are your friends using? What are you being offered? What are you seeing happening in school? And here's things that I really want you to avoid right now. So it's not that heavy-handed, like don't do drugs, you're going to die, you're going to go to jail. I'm sorry to say that in that harsh way. I know everyone's had that experience, but that's the place that sometimes we go with very young kids. And I don't think that's effective or helpful, right?
When you had just mentioned about age 8 to 10, and then in your presentation, it alluded to not giving the kids too much information. So at the 8 to 10 range, to start to have the conversation, what kind of information could be included at that age?
Yeah, well, I did start to say, and I talked to parents around me that, kids need to be aware that substances are going to be available and offered probably starting in junior high. There's a different culture in transitioning from elementary to school to junior high. In elementary school, they're monitored even during lunch. They can't leave school property. They're not hanging out unsupervised. Whatever cultural age you find that youth are unsupervised, that's when they're going to start to experiment with substances and get access from families, peers, and other channels. So I really just started to talk to my own kids and advising other folks, like talk about what might be available, and also talking about delaying as long as possible in a realistic, pragmatic way. Like, yeah, they're going to be drugs, but it's probably better if you wait till you're 16 to try X, Y, or Z. Now, this is my approach in my family because I support harm reduction and I'm very aware of drug poisoning deaths. But in your family, you might have different values and different parameters based on someone being, abstinent or in recovery. You might have faith-based reasons. You might have other values where you're saying no substances, but you have to have those honest conversations with young people. And at the same time, emphasizing the safety net, right? If you experiment with something, if you use something, if you make a mistake, if you make a choice, I'm still going to be here for you. I'm going to be there to support you. And these are things also I learned that Moms for Moms Stop the Harm do in different ways,
Mm-hmm.
The kind of unconditional love and support.
Another question that just popped in. Do you think that helicopter parents, as they're sometimes called, can lead to youth or young adults hiding their use or their addictions?
Yeah, well, this is another thing that's so complicated, and yeah, there's that idea that millennials generationally have been helicopter parented with constant supervision. There is a commentary that came out recently, and it's a little bit provocative from a bunch of people working in youth mental health. And it kind of sparked a little bit of agreement from me in that it maybe doesn't cause youth hiding, but what they argue is that the generation of young people from millennials onwards have had very little independence from parents. So for example, I was sharing with my husband, we were talking about this. When I grew up, I took the subway by myself in grade 1 in Toronto. My parents were divorced. So I took the subway from my mom's house to my dad's house, sometimes with my 4-year-old sister in tow. And we moved around the community. We went places on our own. We did stuff. We had a lot of independence and freedom. We stayed out all night until the streetlights came on. I don't mean to sound like a old Gen X or a boomer, but they're saying, it's good in some ways. The culture has shifted. We're more in touch with what's happening with our kids. We're more in touch with mental health. We have different vocabularies for knowing what's happening. But in other ways, kids have had very little freedom from us as parents to make mistakes, to develop you know, that capacity to chart their own course. So they're just saying like, this is a broad population trend and it's probably influenced mental health outcomes. But I wouldn't want to weaponize it in a way that blames parents, like, oh, you were too involved in your kid's life. That doesn't really seem productive. I think we have to look at what's going on socially and culturally, and what people need, you know.
Thank you. And we just have maybe one more comment in the chat, and then we will wrap it up. Since my son passed, I've had several conversations with my 9-year-old granddaughter about alcohol and drug use. No judgment or stigma. I'm always impressed by how much she already knows and how open she is to those discussions. And I just think that's so true, is having those open discussions, having those connections. That's what I really hear through all of this, is to be aware and just to be connected without judgment, and just how well we stayed connected with our kids, and to be available for them.
Yeah, and if that connection is challenging or conflicting or sometimes severed, that's also not blaming individuals, because problematic use of substances is so complex and multifactorial. You know, it is about relationships and support in some sense, but it's also about that person's personality, you know, genetic factors, sometimes what they're hardwired to enjoy or take risks around. So yes, let's focus on what we can do, but also knowing that some things are beyond our control, and we did the best we could with the tools that we have. And I really like Sarah's point. We're not trying to adultify kids and have really deep conversations, but 9-year-olds and 10-year-olds, how could they not hear about people dying from unregulated drugs? It's in the news. It's touching all of our families and our communities. It's hard to find someone, if it's not our personal experience, someone in our network who's had that experience, right? So they are listening, they are hearing. And so this is a good way to open the conversation and talk about these things and share things in age-appropriate ways, because if we don't talk to them, they will hear it from their friends, and they'll probably search it up online, and they may see things that are incorrect or scary. So I always want to be that first point of contact, you know, for younger people.
Absolutely, because the kids are very resourceful. So if they have a question, and then with the internet out there, we want to make sure that they're getting the correct information, and keep, because the connection, even what we know and we share in Mom Stop the Harm, it's always about the connection and coming from that heart-centered place that provides that support in a way that others, you know, data and things can't. So thank you for all of your presentation today. I love the slides, and I know you're going to send them to me so I can send them out to everybody. And as we take that information and internalize it, to be able to then turn around and make those connections and conversations with our loved ones, with youth, with kids, and then share this out on a wider platform.
Yeah, my one takeaway to folks is the next time you're in a conversation with someone about your lived experience and people say, well, we just need to get into the schools, we need to teach kids. You can say, well, maybe not. Like, you know, there's other things we need to do. There's other places to put our money to reduce harms and to have better supports for people. Yeah.
Mm-hmm. So thank you so much for sharing all your wisdom and your expertise and your heart and your passion with us today, Rebecca. And thank you to everybody that joined us. We appreciate you being with us today, and all the information that's been shared. This will be posted on our YouTube channel, and everybody that was here today and registered will also receive the recording. And I'll wait until we have pulled together all of the information that was in the chat, as well as what Rebecca's been sharing with us. And so you will be able to share it either directly with people that you would like to do that with, or through our YouTube channel. Please check out our YouTube channel. Just put a plug in there quickly, as we have a lot of amazing presentations on there that we've done, like the one today with Rebecca. And I realized as we got started, I did not introduce who I am. And so for those of you that don't know, I'm Antoinette Gravel-Willette, and I am the Stronger Together Canada program coordinator. So thank you, everybody, for your time and being with us today, and take good care. And I'm going to stop the recording now.